Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
We will be talking about treatment updates. I have no conflicts of interest or relationships to disclose. And as noted here, racism, not race, creates and perpetuates health disparities. I'm trying something a little new this time. Typically, I like to go in depth with about 3 abstracts, but I'm going to try and give a little more breadth today as to what was shared at CROI about treatment, because there was so much and it was hard to pare it down. So first we'll talk about ART and pregnancy. I'll give you all an update about IMPACT 2010 data, touch briefly on dolutegravir and neural tube defects as usual, and then also mention something about perinatal transmission. Then we'll spend the most of the time talking about the NADIA Trial, about ART options for drug-resistant HIV or salvage therapy, and touch briefly on the VISEND trial. And lastly, I just wanted to give a couple teasers about the third HIV cure case, Lenacapavir and Islatravir updates, and then a teaser about anchor results, which I know you will be hearing about shortly on March 24th and March 31st, I believe. So let's go forward. So ART and pregnancy. So as a reminder, ART options in pregnancy remain limited. And at previous report backs, I've shared data from the IMPACT 2010 study, which is a global multi-center randomized trial of ART-naive pregnant women with HIV started on ART during 14 to 26 weeks gestation. And they're randomized to either TAF-FTC and dolutegravir, TDF-FTC and dolutegravir, or TDF-FTC and efavirenz. And from the CROI conferences from the 2 years prior, we actually learned that the arms with dolutegravir had superior virologic efficacy and also had closer to expected weight gain in pregnancy, and that the TAF-FTC dolutegravir arm had the lowest rate of adverse pregnancy outcomes through 50 weeks postpartum. This year, they gave a couple other updates on this, and I think the more info we have about TAF and dolutegravir in pregnancy, I think the better, and just the more information we have about ART in pregnancy, the better. And so here they looked at growth of infants with perinatal exposure. I am not a pediatrician, and so what they did was they picked these length for age and weight for age Z-scores, which I'm presuming some people care about more than I probably do as an adult physician. And they found that these length for age and weight for age scores were lower in the efavirenz versus dolutegravir arms, but that within the dolutegravir arm, they were similar between the TDF and TAF arms. Interestingly, weight for length Z-scores showed no difference between the two arms, and their big takeaways were that infants born to mothers starting efavirenz in pregnancy were smaller throughout their infancy, that rates of stunting was high across all of these arms, but higher in the efavirenz arm, and that infant growth was similar following exposure to maternal TDF or TAF with dolutegravir. So that is just a couple other updates from IMPACT 2010. Next, I wanted to share something looking at neural tube defects with periconception dolutegravir use in the United States. So as a reminder, the SAPAMO study in Botswana raised some initial concern about dolutegravir and neural tube defects, though as of April 2020, the incidence of neural tube defects was not statistically significant. And you might all know that in Botswana, they do not supplement the diet with folate, whereas in the US, we do. And so this study group wanted to look at rates of neural tube defects with periconception dolutegravir use in the United States where folic acid supplementation is occurring. And so in the years of 2008 to 2019, they looked at this large cohort of pregnant persons in the US, and it was very large, 35 million people without HIV compared to 3,000 with HIV who were on dolutegravir in early pregnancy, as compared to 20,000 people with HIV on other ARVs in early pregnancy. And they found no increased risk of neural tube defects amongst infants exposed to dolutegravir periconception. The other abstract I just wanted to touch briefly on was about the lack of perinatal transmission in French women with HIV on ART who were virally suppressed. So this was looking at about 1,700 infant and women with HIV pairs in the ANRS EPF registry in France between 2000 and 2017. And these women with HIV who were pregnant were on ART before conception. And among about the 5,500 women who met their criteria, who were treated at conception with any ART combination who did not breastfeed subsequently, no perinatal transmission was observed if the viral load was less than 50 copies per milliliter near the time of delivery. Some takeaway points from just ART in pregnancy. New data from the IMPACT 2010 study continues to reassure us regarding dolutegravir and TAF use in pregnancy and in the postpartum period, that dolutegravir-containing regimens have superior virologic efficacy at delivery, and that TAF-containing regimens have the lowest composite frequency of adverse pregnancy outcomes, that dolutegravir was not associated with neural tube defects in U.S. infants exposed to periconception, and that in this French cohort of women with HIV on ART at conception, with a viral load less than 50, who were not breastfeeding, no perinatal transmission occurred. And then the last thing I just wanted to do is make a plug for the fact that there are the 2021 DHHS perinatal guidelines, and they recommend dolutegravir and TAF as the preferred ART in pregnancy and periconception. Changing gears to ART options for drug-resistant HIV. For background about this, the Dawning study showed that dolutegravir was superior to boosted lopinavir as salvage therapy, and a subsequent sub-analysis that was shared at CROI in 2019 showed that dolutegravir plus 2 NRTIs, regardless of pre-existing resistance-associated mutations to one of the NRTIs, maintained virologic suppression. So basically, that study, the Dawning sub-analysis, really gave a lot of us, sort of not permission, but like some comfort with using Truvada dolutegravir or Descovy dolutegravir in someone with an M184V, and then also extrapolating from that to Biktarvy as well. The other thing in the Dawning sub-analysis that we saw was that dolutegravir, that when you fail, that you can fail with INSTI resistance, but that if you fail on a boosted PI, you generally do not fail with PI resistance. And so with Dawning as the background, we're going to switch gears and talk about NADIA, which is the nucleosides and darunavir dolutegravir in Africa trial, and spend a fair amount of time on NADIA because I think it's quite important and didn't get as much buzz at last year's CROI as I would have hoped. This was a multi-center, non-inferiority randomized trial of people with HIV failing TDF plus either 3TC or FTC and an NNRTI, and then switched to and comparing dolutegravir versus boosted darunavir and TDF versus zidovudine. And this is significant because whereas Dawning looked at dolutegravir versus lopinavir, NADIA said, hey, let's compare dolutegravir to best-in-class PI, which is darunavir. 48-week data from CROI last year showed that dolutegravir was non-inferior to darunavir and that TDF was non-inferior to zidovudine. And then again, those with viral rebound developed INSTI resistance while on dolutegravir, and there were 4 cases of that back then, but there was no PI resistance developed from those who failed while on darunavir. So as a refresher about what the study design was, again, it was of patients who were on TDF, 3TC, FTC, and an NNRTI regimen for at least 6 months with treatment failure, which they defined as a viral load greater than 1,000. They did this 2x2 factorial randomization where they first randomized 464 patients to dolutegravir or darunavir, and then within those arms, randomized them further to TDF 3TC or zidovudine 3TC, which I'll also say AZT here and there. And then they followed them up for 96 weeks, and their primary outcome was looking at viral load less than 400 at week 96. And as a reminder, the viral load less than 400 is oftentimes the cutoff used in international studies for viral suppression. This was done at 7 sites, primarily in Uganda, but also in Kenya and Zimbabwe. Of the study patient population, 61% were female, with a median age of 34, a median CD4 of 189. 50% of them had a CD4 count less than 200, and 28% had a viral load greater than 100,000. And then as far as sort of the ART exposure in this cohort, the median time on first-line ART was 3.7 years. 86% people had a baseline M184V, and 50% of people had a baseline K65R. So this was a treatment-experienced group with a lot of nuke resistance. So the results here, first comparing dolutegravir and darunavir, showed that dolutegravir is non-inferior to darunavir. Similar to the 48-week data, you'll see here again that this was non-inferior for the primary outcome. And then for a secondary outcome, they looked at virologic rebound, again defined as a viral load greater than 1,000. And then they found that of those, within the dolutegravir group, of the 20 who failed, 7 of them failed with dolutegravir resistance or INSTI resistance, and 0 of the 26 who failed on darunavir developed any PI resistance. Then, interestingly, we got some new data here about TDF compared to AZT or zidovudine, and they found that TDF was actually superior to AZT, and that was not the case at 48-week data. Similarly, looking at their secondary outcomes of viral rebound, there were 13 people who failed in the TDF arm as opposed to 33 in the AZT arm, and this was clinically significant. And you'll notice here that there was, on the bottom row, there was nobody who failed with PI resistance or no resistance to darunavir, but people who failed while on dolutegravir did develop INSTI resistance, and that occurred more in the AZT group. This is an image of the subgroup analysis that I took a screenshot from their oral abstract, so pardon the red square around that. But basically, you'll see that in orange, which is the dolutegravir, and blue, which is the darunavir, that these were all kind of non-inferior. And then here's another, this is the subgroup analysis comparing tenofovir versus zidovudine. Again, pardon the red box, but you'll notice here that they do call out, and I appreciate that they call out, the non-inferiority of tenofovir to zidovudine, especially when there is a K65R present. Now, a bit about the dolutegravir resistance-associated mutations. I find this information is always really helpful to see what people fail with and what we're going to anticipate. On the left is, yet again, a screenshot of their RAMs. Here there's 9 because they actually found 2 more. And you'll notice that most of the resistance occurred with people who were on an AZT plus dolutegravir containing regimen, as opposed to a tenofovir plus dolutegravir containing regimen. There was higher level resistance as compared to, again, intermediate level resistance here. And here's a list of the mutations, which I've just put here so that you can have as a resource, and a couple other resistance-associated mutations that also occurred. So last about the sort of ART sort of resistance is the VISEND trial. And this was a 144-week randomized open-label non-inferiority study in Zambia of about 1,200 people with HIV with and without viral suppression. I chose to include this study because they compared in people who were also failing efavirenz or nevirapine, similar to other studies such as Dawning and NADIA. They compared TLD, or tenofovir lamivudine dolutegravir, to TAF FTC dolutegravir. And that's just different because a lot of sub-Saharan Africa uses TLD, and so it was nice to see that data. And then there's a little bit of also weight gain information that I wanted to share. This here is a schematic of their study design. And then as far as their results go, they found that in the people who were virally suppressed, TAF FTC dolutegravir was non-inferior to TLD. And then in people who were not virally suppressed, the viral load greater than 1,000 arm, TAF was FTC dolutegravir was non-inferior to TLD, and then they found that both were superior to the combined PI arm. However, I think there's a caveat here, and perhaps not doing the PI much justice, in that they combined the PI with zidovudine and 3TC, and so we don't really know their results if you were to combine the PI with a TDF-containing regimen. But again, these are sort of second-line PI regimens. And then this is the part that I really thought was interesting, the impact on weight gain. So on the top is the people who were virally suppressed, which again, they not suppressed, but not failing, which they use a viral load less than 1,000 to describe. And you'll see that if you were on efavirenz or nevirapine and had a viral load less than 1,000, and you were switched to TLD or TAF FTC dolutegravir, you had more weight gain in the TAF arm. But that if you were already with a viral load greater than 1,000 and switched to these, there was similar amounts of weight gain in this lower image here. And then of those who were not virally suppressed, in women, there was a higher amount of weight gain with the TAF-containing arm, whereas in men, there was relatively more weight gain in the TLD arm. So some takeaway points for ART options for resistant HIV from the NADIA trial is that the NADIA trial at least affirms the practice of using dolutegravir with less than 2 active NRTIs in the setting of NRTI resistance. It actually changes how active I consider tenofovir to be in the presence of a K65R when paired with dolutegravir. I think traditionally a lot of us think about sort of AZT being hypersusceptible with a K65R, but here tenofovir paired with dolutegravir showed that it was non-inferior to AZT. And then it reaffirms that dolutegravir does fail with INSTI resistance, but that PIs generally do not fail with PI resistance. And then the VISEND trial affirms that we can use either dolutegravir or second-line PIs as second-line therapy. And that in the viral suppression arm, TAF was associated with more weight gain than TLD, but if you were not virally suppressed, TAF was associated with more weight gain than TLD in women, but TLD was associated with more weight gain than TAF in men. And lastly, some very brief topics of interest is this sort of case report of the third HIV cure, or rather HIV remission. So as a reminder, both the Berlin patient and the London patient underwent stem cell transplantation from donors homozygous for the CCR5 delta 32 mutation. And although the London patient, which was shared at CROI 2019, signified that this approach may be replicated after the Berlin patient, which I believe was shared at CROI 2009, using this approach to achieve remission is both high risk and high cost. It's a big deal. At IAS 2020, I shared about the Sao Paulo patient who was thought to achieve remission using dolutegravir, moraviric, and nicotinamide in addition to 3-drug therapy. But unfortunately, just a couple weeks after IAS, that person had virologic rebound at 72 weeks. And so both the Berlin and London patient used stem cell transplantation, but umbilical cord blood cells had not previously been used to achieve HIV remission. That is significant because it's evidently very hard to screen for this CCR5 delta 32 mutation, but umbilical cord tends to be banked and it is easier to screen. And I wanted to share about this case because I think although this is not something that we are doing on a daily basis, I have mentioned to you all before that patients ask about this, and so I wanted to make sure that you were equipped to discuss it with them. So this was a case of a middle-aged U.S. woman of mixed race with HIV and high-risk AML who underwent Haplo-Cord stem cell transplantation. So basically they did a cord blood transfer from a donor who was homozygous for the CCR5 delta 32 mutation. And from what I gathered, there wasn't enough, and so they needed to have some stem cells from a relative. So that is what they used. This patient had 100% chimerism with a donor homozygous for CCR5 delta 32, which is also what we saw in the Berlin and London patients. And this was significant because it was the first time using cord blood cells or using at least a haplo-cord transplant to achieve HIV remission. And here for your resource is kind of the HIV and AML treatment course and when they did their analytic treatment interruption, and we are now at least 14 months into that. Updates on the novel agents Islatravir and Lenacapavir. Islatravir, the NRTTI, I won't discuss much because most studies at CROI 2022 regarding Islatravir were for PrEP, which Dr. Kumbhakar already discussed last week. As she mentioned, it is currently on FDA hold both for prevention and for treatment. And for treatment, it's on hold due to 30 to 50% mean drop in CD4 cell count in these treatment studies. The big takeaway from CROI regarding Islatravir was that the future of Islatravir was uncertain. And then for Lenacapavir, the HIV-1 capsid inhibitor, which is currently on partial FDA hold because of issues with the glass vials, we got 54-week data from the Calibrate study in ART-naive people with HIV, which showed that Q6-month Lenacapavir plus TAF or bictegravir led to viral suppression in 85 to 90% of individuals. And then we also got 52-week data from the Capella study in persons with multi-drug-resistant HIV that combining Q6-month subcutaneous Lenacapavir to an optimized baseline regimen led to viral suppression in 83% of individuals. And then last, I just wanted to introduce the fact that the anchor results were shared at CROI and that soon you will be hearing more from Drs. Stankiewicz, Karita, and Dr. Schouten about these study results. But I just wanted to give a teaser because I thought it was quite significant. And one thing that I thought was really helpful is that they shared what the big anchor study, which was of people with HIV greater than age 35, had the following 4 aims: whether treating anal HSIL is effective at reducing the incidence of anal cancer, determining the safety of the treatments that they used, developing an instrument to measure an impact on quality of life, and to collect clinical specimens and data to do correlative science for predictors and biomarkers. I think I was only aware of aim 1, and I think that's what we all think about when we think about the anchor study, but I thought them sharing all these aims was helpful. And aim 1 ended up randomizing 4,500 people to either high-res anoscopy versus active monitoring between the years 2014 and 2021. 32 cancers were diagnosed, 9 in the treatment arm, 21 in the active monitoring arm, and there was a 57% reduction in anal cancer in the treatment arm, and so the DSMB stopped the study early. And so mostly I just wanted to give this plug that you will soon be hearing more about this, and that is it, because these were just quick, brief teasers. There are no conclusions for those.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.